Dupuytren's contracture. Anatomy includes the palmar fascia and the fourth and fifth fingers. Pathology: when bands of fibrotic tissue forms in the palm and radiates distally towards the fingers, the tissue tightens and shortens, causing permanent finger flexion in the affected fingers. This usually happens bilaterally. However, one is always more affected than the other. Mechanism of injury. There is no true mechanism of injury because there is no direct trauma or injury that occurs for this to happen. The disease is progressive and happens over a period of time. The main cause is due to genetics. Signs and symptoms include thickening of the skin on the palm. Skin on the palm will look puckered or dimpled. Lumps of tissue forms on the skin. This is usually called a node. And fingers will be permanently flexed towards the palm. This causes trouble for the patient to be able to do daily activities such as grasping objects. The patient usually does not experience pain. Differential diagnosis can be palmar tendinitis, fibromatosis, prolapsed flexor tendon, tumor on the tendon sheath, calluses, and ganglion cyst. There are no special tests. It is usually diagnosed through looking at the hand. There is no mulligan. Predisposing factors include being an elderly man, previous family history, overuse of tobacco or alcohol, and having diabetes. To treat and manage, you can choose a surgical or non-surgical route. Non-surgical, they use steroid injections and splinting to keep fingers from flexing. Surgical includes a fasciotomy and a subtotal palmar fasciotomy. You can refer a patient to a physical therapy office, a plastic surgeon, or an orthopedic. You can immobilize with the splint shown in the previous slide. There is no prevention for this disease. If you know your family history has this gene, then you can refrain from overuse of tobacco or alcohol or other things that could make it worse. My PCOT includes 33 patients with Dupuytren's contracture. A total of 50 hands were used. They looked to see which surgery was better for a result to passively move fingers. They compared the open limited fasciotomy and percutaneous needle fasciotomy. The results were the open limited fasciotomy allows for more passive extension post-surgery. There was a year follow-up after the surgeries.